Hello, all of the judges. My name is Derika Karnamaya Sinta. I'm from Indonesia. First of all, I want to thank you for the opportunity given to me in this International Laboratory Medicine Case Contest. I'm here to talk to you about my interesting case report with the title Hepatitis C infection and autoimmune hemolytic anemia in patient with colon B-cell non-Hodgkin lymphoma. Lymphoma constitute the third most common neoplasm in head and neck region arising from the lymphoreticular system. Malignant lymphoma are divided into Hodgkin disease and non-Hodgkin lymphoma. Extranodal disease with or without lymph node involvement is more common among non-Hodgkin lymphoma patients. Gastrointestinal lymphoma accounts for 5 until 10% of all non-Hodgkin lymphoma. B-cell lymphoma of the colon is the third most common malignancy of the colon after carcinoma and carcinoid, though its incidence is less than 0.5%. Clinical manifestation of hepatitis C virus include hepatic and extrahepatic disorder. In addition to liver disorder, hepatitis C virus is also associated with extrahepatic immune manifestation and B-cell NHL, especially B-cell lymphoma. Secondary autoimmune hemolytic anemia accounts for about 50% of all autoimmune hemolytic anemia patients and mainly occur secondary to LPD and autoimmune disease. This presentation will explain about the rare case of colon B-cell lymphoma accompanied by hepatitis C and autoimmune hemolytic anemia. This is the case description. In this case report, we have 47 years old male with the main complaint of abdominal pain, especially in the lower of left abdominal region for the last 10 months. The pain has been going and coming. This patient also had a history of continuous diarrhea in the last 4 months, more than 5 times a day, yellowish color with no blood. He also experienced jaundice at eye since 2 months before admission. This patient also experienced weight loss in 4 months. It was almost 80 kilograms. From his head and neck physical examination, we found anemic conjunctiva, icteric sclera, and enlargement of lymph node with a size of 1 centimeter by 1 centimeter single nodule. Now we will move on the laboratory examination. For the laboratory examination, we found normochromic and isocytosis anemia, lymphopenia, positive Coombs test, direct and indirect hyperbilirubinemia, increased aspartate transaminase 1.5 times upper range limit, and alanine transaminase or ALT 3 times upper range limit. We also found increased level of lactate dehydrogenase, reactive hepatitis C virus, and positive hepatitis C virus RNA by PCR. The colon biopsies were performed 3 times. The last one on November 12, 2019, colon biopsy with immunophenotype examination leads to non-Hodgkin lymphoma B-cell type. From abdominal CT scan, we found multiple para-aortic lymphadenopathy and left para-iliaca due to NHL and dilatation in vena cava inferior, left vena renalis, bilateral vena iliaca due to congestive. Now we will move on to the case analysis. Following the principle of lymphoma classification, lymphoma diagnosis is based on the appreciation of morphologic and immunophenotypic features and genetic characteristics in the context of clinical presentation. Nearly 25% of NHL cases arise in extranodal location, and most of them are seen involving in both nodal and extranodal site. The most common NHL subtypes by far in developed countries are diffuse large B-cell lymphoma, about 30%. In this patient, the immunophenotype examination leads to non-Hodgkin lymphoma B-cell type. Lymphoma involving the colon and rectum is rare and can occur either as primary colorectal lymphoma or as a manifestation of systemic disease. Primary colorectal lymphoma accounts for 1.4% of all cases of non-Hodgkin lymphoma and less than 1% of all colorectal malignancy. Most patients with primary colorectal lymphoma present with abdominal pain and obstruction is unusual. This is in accordance with what happened to this patient who came to the hospital complaining of abdominal pain. There are several risk factors for NHL, including one of them is viruses pathogen, such as hepatitis C virus. For this patient, we found reactive anti-HCV from immunology examination and positive HCV RNA by PCR. We also found increased levels of AST and ALT. The common feature of HCV-related BNHL are long duration infection, 15 years, and frequent involvement of extranodal site. The chronic infection is also responsible for chronic systemic inflammation that will lead to an increased risk of extrahepatic cancers. Three possible theories that might explain the process of hepatitis C virus transformation and its correlation with B-cell non-Hodgkin lymphoma. The first one is proliferation of lymphocyte receptor. The second one is replication of HCV occurred inside the B-cell, and the last one is permanent damage of B-cell caused by the intracellular virus. Autoimmune hemolytic anemia can be divided into primary and secondary. Secondary autoimmune hemolytic anemia accounts for about 50% of a autoimmune hemolytic anemia patient and mainly occurs secondary to lymphoproliferative disorder and autoimmune disease. The most common signs of LPD in secondary autoimmune hemolytic anemia are chronic lymphocytic leukemia and lymphoma, which can be both NHL and Hodgkin lymphoma. B or T cell NHL can be accompanied by autoimmune hemolytic anemia, but the most common is B-cell NHL. In autoimmune hemolytic anemia, increased indirect bilirubin level, low or absent serum haptoglobin, elevated lactate dehydrogenase, and an increase of urinary urobilinogen are all hallmark of hemolysis. Hemoglobinuria, which is an early symptoms, indicate intravascular hemolysis. A positive direct antiglobulin test, or TAT, also known as the home test, is essential for diagnosis. In this patient, the laboratory results showed normochromic anisocytosis anemia, lymphopenia, positive home test, direct and indirect hyperbilirubinemia, and increase of LDH. I will explain about the mechanism of autoimmune hemolytic anemia in non-Hodgkin lymphoma patient. In non-Hodgkin lymphoma, the antibody may be clonal and produced by the lymphoma cells in some cases. In addition, autoimmune phenomena in non-Hodgkin lymphoma may occur before or upon diagnosis, during or after treatment. So in conclusion, there is close relationship between hepatitis C infection or chronic infection and NHL. The hepatitis C infection in this patient is probably chronic, although the time of infection is unclear. Autoimmune hemolytic anemia in this patient secondary caused by the lymphoproliferative disorder that is NHL. So for the take-home message, it is important to carry out adequate treatment for patients with hepatitis C because the long-term impact will provide adverse outcomes for patients if not accompanied by appropriate management. And that brings us to the end. I'd like to thank you for your time and attention. Thank you so much and see you.